Well, look, thank you to everyone on the committee, and it's a real pleasure to be here to talk about the things that are happening at PHARMAC, which I believe are overwhelmingly positive. That is thanks to the leadership of the chair, Paula Bennett, and Natalie McMurtry, who is new. I think this is the first time she's appeared before the committee. She's actually picked up her life in Alberta, Canada, moved from Edmonton to Wellington, not just for slightly warmer weather, but also for a really great challenge. And I think it's a real point of pride for New Zealand that our model is globally respected and that Natalie was prepared to move here. So welcome, and we're very pleased to have you already doing a fabulous job. When it comes to some of the highlights recently, obviously, we've had a serious uplift in the medicines budget, $604 million in mid-2024. That's led to 31 new listings and 52 widenings of access in the 24-25 year. So far, we've widened access to another 13 medicines. In 23-24, we saw 4.2 million New Zealanders receive funded medicines. And in budget 24, we had a total of $7 billion over 4 years. So we've never spent so much. And I've got to say the PHARMAC team have responded really well to the demand. I mean, these guys, they love buying medicines. That's what they come to work for. They're getting good deals. However, they have responded to a really large increase in volume. So we thank them for that. We've also resolved a long-standing problem of who exactly in New Zealand buys or purchases medical devices for the government. That's been a split, an uneasy split, I would say, between PHARMAC and Health New Zealand for a long time. Minister Brown and I have come up with a resolution agreed by Cabinet that there will be some devices bought by PHARMAC and some by Health New Zealand, roughly half and half. I think there's about 28 categories with each organisation, and that has meant that both sides can get down to what they're good at. Generally, Health New Zealand dealing with things such as consumables and some machinery where connection with the clinicians is important. PHARMAC dealing with materials that generally claim to have a therapeutic benefit. We have worked through budget 25 or at least and 26 on really a new way of budgeting. Our goal is for PHARMAC to make better budget bids to demonstrate the value to the rest of government of greater investment in medicines and devices, to demonstrate how it can actually uplift society and save the government money elsewhere if we buy more. That's very different from PHARMAC's traditional role of managing within a fixed budget. We have an IT upgrade of around $7 million that has been funded by successful litigation from the COVID era, some of that money being kept and used for IT upgrades, because while I mentioned the hard work by the PHARMAC people, it's fair to say they've been working with some clunky gear. The government's also made a number of other changes. For example, prescriptions now can be as long as 12 months, and that has impacts in some ways because there are fewer fees, but it also makes life a lot better for a lot of people who have medication over a long period of time. It also takes demand off GPs. The PHARMAC reset is very important. We had a medicine summit, and I know some of the members of the committee were at that about a month ago. A lot of the people who were participants in the summit had been actively picketing PHARMAC only 2.5 years ago. So we have gone through a total reset. As per my letter of expectations, I think Paula has stewarded the organisation extremely well to start seeing clinicians, vendors, patients as partners in a shared mission rather than opponents in an adversarial relationship. So we're very pleased about the fact that even that meeting is now possible, and there's real substance to it, such as the Patients Advocacy Group. We have begun publicly funding cancer medicines in new settings. That's a major development. There are people who paid their taxes all their life and paid for their health insurance. They start their cancer treatment in a private setting, and then PHARMAC funds a medicine. In order to get access to that medicine publicly funded, they would have to change clinician and change facility while they have cancer. That is just cruel. That is no longer necessary from now. And we also are working hard on faster processing. This has obviously been a challenge given the volume uplift. Volume uplift is a good thing. We're funding more medicines, we're spending more money, that's great, but it's also put pressure, so we're working through that. So look, altogether, I feel really proud to be the Minister responsible for PHARMAC. I think that a lot of positive developments are occurring. challenges unquestionably, but we're facing them very well.
Excellent, thank you. Questions from members? Ricardo, Jenny, Asha.
Just get a really quick one.
Yeah.
On page 58 of your report, noting your comments you made around building confidence in patients, why do you think that despite all of that, there's still a increase in the number of critics within Māori, and that you haven't really made much progress in relationship to an increase in Māori trust and confidence in PHARMAC? What do you think you need to do in order to achieve that?
I think we need to deliver medicines faster and better and have a more compassionate relationship with clinicians, patients, and vendors, and see it as a shared enterprise rather than an adversarial relationship. All of the things that we're doing, there's no reason to think that Māori are different from anyone else in the way that they would respond to those goals.
Do you think any other government policies could be contributing negatively to this lack of increase in Māori trust in PHARMAC and the health system?
No, I don't think so. I think to suggest that Māori people somehow bring prejudices from one area to the next, actually, I think you'll find that we're quite sophisticated.
Jenny.
Oh, thank you. Noting that coalition government, New Zealand First National and ACT wanted to ensure patient voice was at the centre and were involved in the decision-making processes, how has PHARMAC worked to achieve those coalition commitments?
So if you look at someone like Malcolm Mulholland, I mean, for years, the most vocal and often the most trenchant critic, he is now chairing the Consumer Advocacy Committee. So we have brought people who used to be picketing outside PHARMAC, inside PHARMAC. That was unthinkable. I want to credit Paula with that, and also our new Chief Executive, Natalie. So that is one thing that we've done. And our general approach in my letter of expectations to PHARMAC has been, look, there's only 5 million of us. You know, we've got shared problems. We don't have time to fight each other. And that is the spirit that they seem to be taking on.
Thank you.
Asha.
Thanks, Mr. Chair, and with your forbearance, a set of related questions. The culture review that you instigated, why hasn't it been reported in full?
I think, well, I'll let Paula answer that.
Yes,
Looks like she's
sorry, yeah.
Yeah.
It was the board that commissioned that work. So certainly from our perspective, it does go into staffing issues, and it went into quite a bit of that. And so the advice that we got was that actually doing the executive summary was enough for that.
And can you describe the patient workshops that were held last year and who initiated those, the minister or the board?
Well, the minister was very clear in his letter of expectations and in our regular meetings that he wanted, as the member quite rightly said, you know, patient voice is being heard a lot more. And I felt that, so it was the board that actually commissioned those workshops. I felt like it had got to a stage where there was sort of almost such a divide. And we did have an opportunity with myself coming in the chair and things like that. How could we capitalise on that to actually close that gap? And I felt for us to do that, we had to look eye to eye. We had to be able to take the honesty, excuse me, and the bluntness of some of the hurt that had gone on, and to do that we had to do that face to face and in a room, and genuinely not run it the PHARMAC way, actually run it their way.
Hearing that there was significant concerns being raised by patient groups, what steps did you take as a board to make sure in a setting where tensions might be high, those concerns weren't unreasonably personalised at staff?
So for the first one in particular, staff were not there. So there was the board were there, and I want to acknowledge Dr. Margaret Walsh from the board as well. So only board members were there. There was no staff members there at all. And then in the second meeting, not for all of it, but for some of it, there were staff members there. From that perspective, I felt like I was there to try and be the buffer if needed.
Thank you. A single employee got a $357,000 payout in the year under review. Was that former Chief Executive Sarah Fitt?
It's an employment matter, so that's as stated in the annual report, there was that one payment that was made under employment, under their employment contract.
When did you advise the minister that an employee department departing PHARMAC would receive a $350,000?
I don't think I
payment?
ever gave the minister a number. It's
Oh, sure.
confidential and
Please,
it's
Mr. Chair.
what's to be expected in negotiations for someone, cessation payment for someone leaving.
This is a $2 billion a year operation buying medicines for 4.2 million New Zealanders. Having the right leadership at the head is absolutely critical, and I think the board's managed it very well.
That equates to at least 8 months of salary of the highest paid individual at PHARMAC during that time. Do you consider that to be good use of taxpayer funds?
Well, you know, my views about employment law are on record and fairly expansive, but we are bound by the laws of this country, and we have done everything that we need to under them.
Did you bungle your management of Sarah Fitt's exit and cost the taxpayers $350,000?
Well, I wasn't involved as the minister. That is a
That's a
board
question to Ms. Bennett.
issue. And as far as I'm concerned, the board has operated very effectively in challenging circumstances. As I said, you had a group of people who were protesting outside PHARMAC are now inside the tent working together on challenges for all New Zealanders. I think that's a good outcome.
Cam,
I think the changes that have happened, as we've seen in the last 9 months with having Brendan Boyle in an acting role and now with our new chief executive, the truth is we were in negotiations, as you would with someone exiting. They had an employment agreement. We negotiated that. We did everything within our powers to actually do the best for New Zealanders and New Zealand taxpayers. But that was the terms of the agreement that I got inherited. And that's what it is.
This is well
Cam,
beyond the
thank you,
norm
Chair.
in the public
Cam.
service.
Thank you, Chair. Minister, you've spoken about the expanding volume of medicines and the widening of medicines. How has PHARMAC managed to increase access to medicines for New Zealand? What has PHARMAC had to undertake to do that?
Well, it sounds easy, but actually spending money and doing it well is a major challenge. So if you look at the people that work at the front line of PHARMAC, they have had to work very hard to make sure and not take the soft options and say, oh, we've got this money, we'll lower our standards. They haven't lowered their standards. They continue to seek savings wherever possible. And actually just recently, they've managed to fund a whole bunch of new drugs by saving money on their current expenditure. So they've had to keep their foot right to the floor, pedal to the metal. They've had to make sure that they are evaluating each new proposition carefully and judiciously, and then negotiating hard to get good prices so Kiwis get the maximum medicine.
Hamish.
Excellent, thank you, Minister. How do you see PHARMAC supporting the wider healthcare system in New Zealand?
Well, first of all, the availability of medicines is absolutely crucial. And getting those at a competitive price, a lower price than we would get without the PHARMAC model, that's really important. So we have protected as a government the integrity of the model, the independence of PHARMAC, and made sure that we've got the right people in the right places to make it effective. That's the first thing. The second thing is that it can actually seek win-wins if it has good relationships with vendors, patients, and clinicians. And building those relationships is one thing we're really focused on. Again, shared purpose, not adversarial relationships. And that's really been that was in my initial letter of expectations way back at the start of 24. And then finally, finding new frontiers. So we are now actively investigating ways that the government overall could save money if we invested in more medicines and more devices. And we're going to be taking better budget bids, making the case that if we invested more in technology, we can solve some of the seemingly irreconcilable challenges this country has with an aging population, infinite demand for healthcare. The only way you can deal with that is to increase productivity. The best way to do that is with technology.
So, it's up, Mr. Chair.
Yep.
Thank you.
So these savings that PHARMAC has delivered, how are they going to benefit New Zealanders?
So when PHARMAC can renegotiate a deal, perhaps something goes off label and they get a cheaper price, perhaps a contract ends and they go for a substitute which they can get better. That frees up, often tens of millions of dollars. And then they look at their overall budget and say, okay, well, we've squared that old thing away and we're getting a better deal now. With the surplus money, we can go further down the options for investment list and get people more medicines they would not have otherwise had. This doesn't involve the taxpayer paying more. It's just that PHARMAC are constantly crunching down, negotiating better deals and buying more for the same amount.
And patents coming off, obviously.
Sorry, yeah.
Well, that's how we
Thank
can renegotiate and get a much better price. And I mean, it's pretty staggering, 4.1 million New Zealanders actually access medicines that PHARMAC has negotiated. And we've seen from the uplift another 250,000 people that have got access to medicines because of the budget uplift from last year. So that's pretty staggering too.
Yes, it's up. So with kind of technology and talking about new medicines coming along, we're seeing medicines coming along that maybe have different components, may not be directly just a compound which someone takes. CAR T cells probably a prime example. How do you think that's going to fit in with the PHARMAC budget, or is that going to be more, how are you going to cooperate with Health New Zealand to fund some of these newer treatment options?
Well, there's a clear delineation between devices and medicines. So that's how we share our responsibilities with Health NZ. But, we are encouraging PHARMAC, or I'm encouraging PHARMAC, I'm encouraging these guys to take a proactive approach. You still require a vendor to actually make an application for funding. But I'm encouraging PHARMAC to say, well, hey, look, maybe we need to make better budget bids. There's things we could do that will save elsewhere. So if you look at someone going through chemo, for months at a time, awful for them, awful amount of cost. I don't claim to be a medical expert, but it appears that CAR T can actually save an awful lot of pain. And even though it may be more expensive up front, might save the taxpayer money overall. So, these are the kinds of things where I think it's critical that PHARMAC has got a mission to get New Zealand to the technology frontier. We're not going to do it by just importing and training more people. We will run out of people. We need more technology to increase the productivity of our health workforce.
Supplementary, Mr. Chair. Does that mean that cellular therapies, which I hope you've had a chance to have some pseudoephedrine, Minister?
Well, someone should legalise that.
Cellular therapies like CAR T, which are not, as I understand it, a pharmaceutical. They're made from the individual's cell outside the body in a lab, would be have a health technology assessment done by PHARMAC. Is that how you see cellular therapies working?
Well, I would certainly look at the legislation and think that's a possibility, but operationally, that's up to PHARMAC.
Ingrid.
Sorry, just to you, Mr. Chair. Look, I know you've only got a few more minutes with the Minister and we're going to be here for, I'd love to, and with Dr. Margaret here as well, would love to explore innovations and what's coming up and how we actually do address some of those real complexities. So we willingly and happily spend more time on that because I think it's the biggest challenge that we've got going forward across the whole health system.
Excellent. Ingrid.
Just a couple of quick steps on Dr. Verrill's initial question. Were non-disclosure agreements involved in the employment matter that she referred to? And do you think that's appropriate for taxpayers? Will you release the amount of legal fees spent either internally or externally relating to that employment matter?
There certainly are non-disclosure agreements with it and within employment law. So for both of those reasons and within the contract, I am limited in what I can say and what I can do. And actually that's out of respect for anyone, quite frankly. And I certainly have respect for the previous chief executive and I will be abiding by that.
And does the Minister think that's appropriate given that it's taxpayer funding?
Yes, I do. People might want to start casting blame about, but the chair and the board inherited a person who had been hired before their time with a contract that they didn't sign under employment law that they're not responsible for. And I think given those factors, they have actually navigated the situation extremely well and PHARMAC is going from strength to strength.
Will you release the legal costs to the taxpayer
Ingrid.
involved with that exit, which is the other part of the question?
Can I check if I can? So sorry, just to not be able to answer that directly and get it. And I might be able to ask one of my team, but
Different angle.
yeah, I'm happy to. Thank you.
I've got, Carlos, you haven't had one? You go.
Yes.
Yes.
So we heard a lot about your achievement in the past 12 months. We actually buy more, wider assets and more saving. So what's your next area of focus for PHARMAC?
Oh, they're not my achievements. They're the achievements of the chair, the chief executive, and just under a couple of hundred PHARMAC workers who I think really deserve our praise. All I do is write them a letter of expectations a couple of times a year. So they're their achievements. But where do I want to see them focus next? Well, look, the culture is coming well. The devices are being fixed. I think the next big thing is transforming the way that we do budget bids for medicines, as I've alluded to a couple of times. We want to go to the Minister of Finance and say, hey, funding more medical technology could be very good for you.
So on that.
Sup there, yes.
And obviously the next budget bid coming up, you might like to look at the New Zealand First Coalition Agreement. That might be helpful.
Well, I tell you what, it might, but I'm sure the Minister of Finance can read, and it hasn't worked for us so far, so we're trying something new.
Dr. Vera, primary.
Note 22 to the annual report says total expenses in the financial year under review was $238 million lower than budget. Why was that?
So our, and we can go right through finances, really happily with you and get the team up. For some of that, it is, we paid back the government for the Novavax vaccine. So that was about $281 million. For the expenditure part as well, we have kept some money, I believe, so that we can then pay for the medicines from last year into this year.
Just on that, we discussed that at last annual review. At last annual review, there was money from the CRIF, the COVID funds, that had to be returned to the centre. But that's not the issue listed in note 22 for this annual review. That's described as being part of the National Pharmaceuticals Purchasing Appropriation and to do also with the COVID vaccine. Now, that fund is for spending on medicine. So I'm wondering why you didn't spend $238 million on medicines.
I might get the team to speak to that more, sorry, so that I'm getting myself not confused and mixed up.
I focus on the budget for medicines, and I let the accounting treatments from year to year be dealt with by the team.
Well, I imagine you'd be very disappointed if $238 million available for medicines that you had won through negotiations with your Minister of Finance didn't get spent.
Well, not necessarily, because if I was obliged to keep that 200 going year after year, then we'd have a big disappointment in the year to follow. That's actually what this government inherited, was a massive fiscal cliff. We had to put in $1.8 billion to fill in the promises that had been made but not delivered in the long term.
Well, Minister and Mr. Chair, if I may, there could be an alternative situation, Minister, which was that actually the COVID requirements for COVID funding that perhaps were represented to you were not as high as actually required. And the statements that the agency made prior to your first budget inflated the likely future costs of medicine, giving the appearance of much greater funding need than there actually was.
Well, I can assure you that spending every dollar.
Well, that's $238 million sitting on the table.
Yeah. We can speak to the actual
Oh
numbers.
God, you better bail them out.
Well, no, we're just going to tell you the truth.
We're just trying to find someone that can explain accounting simple enough for you.
If you recall,
Touche.
we were expecting a large amount of vaccines coming in for COVID.
Oh.
The budget that was put together originally allowed for that to be expensed in the 24-25 year, but because that COVID vaccine failed MedSafe, we didn't have it available to spend in the current year. That's why we are so much lower.
Mr. Chair,
So
this is exactly the same conversation that we had at last annual review, and I invite you to go back to the transcript of that hearing where we had exactly that decision. It was a single year transfer in the preceding year's annual review. So how on earth can it be the case? And now in the National Pharmaceuticals Purchasing Appropriation, as opposed to the COVID one?
Because we hadn't negotiated with the company to get that rebate, because the contract had been done so badly during the COVID episode, and it was just a dreadful, you would never write a contract like that ever again. So what happened was we had to appropriate the money. So that's why it was sitting there last year. It was after the last year's select committee that we've actually got to a negotiation. That negotiation was really hard because legally they didn't have to refund and they didn't have to take it back. So we had to go in and try and do a fair negotiation to then return that funding back to the government. And yes, we'd appropriated it and we then refunded it. I can promise you the only money that we've carried over is because of promises that we've made about a particular medicine that we're funding, and it's not coming in until more into the second year than it was in that first year.
So just to be clear, in relation to your earlier comment, it's not the case that I negotiated with the Minister of Finance to have money spent that has subsequently not been spent. I would notice if we lost $230 million, what the case is that we have had a rebate, which has had to be treated over several years through different accounting treatments in order to get the money where it rightfully ought to be. Along the way, PHARMAC has managed to fund $7 million of IT upgrades, which were long overdue, using some of the proceeds of that rebate. Very well negotiated by the chair, I might add.
So how's it treated?
Coming over here to Cam.
Supplementary, Mr Chair, supplementary.
Thank you, Chair.
Coming to
My question is about the role that PHARMAC has in procuring child immunisations and vaccines for contributing to the government's target of increasing child immunisation rates. Could you speak to what PHARMAC's role is in that area?
Yeah, so PHARMAC has a different role when it comes to vaccines than from other things where we actually buy them and store them. We don't just negotiate the contracts and fund them. So we are involved in stockpiling MMR vaccines. If I remember rightly, I might be corrected, there's 138,000 stockpiled right now. For context, during the 2019 measles outbreak, 88,000 were issued over a 2-month period. PHARMAC have been constantly negotiating to get more MMR vaccines in, scouring the world to boost our supply and keep that buffer of 100,000 in place. So when it comes to childhood immunisation, we have a vital role. And we have kept ahead of demand through a very vulnerable time. The real shame is that immunisation rates dropped so dramatically between 2017 and 2023 that we are now playing catch up, but PHARMAC certainly playing a noble role in assisting that catch up.
I think it's one of the most remarkable things that the PHARMAC staff do, actually, the experts, trying to work out what people are going to do, what might come our way, like the measles outbreak that we've seen, how we get in front of that and yet not overspend and have stuff sitting there that we then need to throw out, which does happen occasionally, of course, but trying to get that balance, how this team does that, I just find absolutely remarkable. Yeah. And with the measles outbreak, as the Minister said, we had, I think we had 110,000 doses in New Zealand at that time, and quite correctly, the last time we had an outbreak and they did a big push like that, it was about 88,000. But by the time I rang, 2 hours later, the team had already ordered more and they were on their way,
All right, we're very close. Time is up.
I was just, yes, please, Mr. Chair. How does PHARMAC account for the economic benefit from a vaccine? Because of course it is a preventative measure. Some of the only preventive measures we have for some of these diseases. How does PHARMAC actually account for the economic gain from vaccines?
Well, it's a technical question. I don't know, Natalie might be.
I can take it.
Come onto the field in the final quarter, yeah.
So through the health technology assessment process, team does quite an in-depth analysis. They look at quality adjusted life years, population impact, and use factors of consideration to look at not only the math along that, but actually the impact on people to get an estimate of that broad population impact. And I think, as always, when the team evaluates medicines, they try to have the greatest value for the most number of people and balance that against high health needs populations. And when there are higher health needs that may impact a smaller number of people, take that into account through the various mechanisms. Does that help?
Yes, thank you.
Thank you. Very good.
Thank you very much, team.
Thank you.
thank you very much to members of the committee. I'm going to make some opening remarks, and then if the committee would like, give Natalie an opportunity to perhaps introduce herself and her background a little bit more. So I wanted to start by saying I'm just so incredibly proud of PHARMAC, and particularly in the last 12 months. I have seen what they've accomplished in the last year, and it is just absolutely fundamentally different an organisation than it certainly was 2 years ago and even at the beginning of last year. You can see it, you can feel it, you can read it in the results that we're getting and the feedback that we're getting from the public, and that's incredibly enlightening. I mean, as the minister said, you know, sort of 83 new listings or widening access. With that 604 million, the expectation was that we would probably get about 45 to 50. But due to their negotiating, due to the work that they did, I mean, within weeks of getting confirmation that we would get that funding, we had new medicines going out. So the minister's quite right. There's a bunch of people there that were just sitting there. Of those, we had 33 cancer and 33 non-cancer. So we got to 66 within that, with the funding from the 604 million, but we actually did 83 in that financial year. And the reason is, as we were saying, because of the negotiating, because patients coming off. And so often we think we can only get new medicines with new money, but we prove through the $150 million worth of savings that we're making that actually we can still do our job and do it well. It's just harder to reach deeper into that OFI and into that list. So far, I'm going to get my number wrong now because it changed today with the Roche bundle went out this morning, which is pretty exciting. But our numbers now, let me get it right. As of this 25-26, our widened access has been 14 and the new listings is 4. So the total has been 18 so far. And that's with us not getting a budget uplift for medicines as such in the last budget. And that again has just been, you know, I think today's Chief Executive might like to speak a little bit more to it at some stage if there's questions, but that bundling from Roche has been really interesting as to how you can then, you're literally negotiating and saying, well, we'll pay this price, but we'd like this one for free, or we'd like this one to come in at cost neutral and make that sort of stuff. The minister talked about the medical devices. Just thank goodness there's a decision, to be quite frank. So of the 55 different categories that they did through medical devices, we got 27 of them, and Health New Zealand have got 28 of them. Of that, for the first time in New Zealand, we have got a comprehensive list now of 220,000 medical devices. So when I was here last time, Dr. Aisha, we were saying how hard it was to get that list together and know what was actually in the health system, and that, you know, this hospital might call something, you know, this device that, and then another hospital had a completely different term for it. So being able to get that'll be the first time in New Zealand, as I say, that we've actually had a comprehensive list of what we've got in there. I'd love to talk innovation pathways, but I think that's up to the committee as to how much they kind of want to go there. I really want to talk more about the PHARMAC reset, which I just think is absolutely changing the whole organisation, so both internally and externally. So we've got a stage 1, which is a 12-month reset, going then for stage 2, which is another 4 years to take. The first stage is to look at our vision and our strategic vision, enhancing consumer engagement and trust, and improving internal processes. So we're well on the way with that, and having Dr. Malcolm Holland's team of 10 really as part of that is proving invaluable, quite frankly, as to how we look. Next big steps, which we could talk about if you want to, is how we now engage differently with clinicians. And I know that that Margaret has ideas and views on how we could be using those teams, but looking at how we're assessing and how we're technically getting the information that we need, and also working with Big Pharma, which is really interesting. So I introduced Dr. Margaret Walter properly. So been on the board now for nearly 3 years, 2.5, coming up to 3 years, comes from a respiratory clinical background and held various high-level health management roles. So I brought her for her expertise because she's incredible. A smart woman brings smarter ones with them. That's what I've always thought. So it's on that note that I introduce you properly to Natalie McMurtry. So Natalie's been 11 weeks in the job. So if we're a little bit between us. We're doing our best and we've got a fantastic team there as well. But can I hand to,
Absolutely.
yeah, thank you, Mr. Chair.
Absolutely.
Thank you, Mr. Chairman, committee members. I'm extremely grateful to be here representing PHARMAC. I've come, as the minister said, from Canada, Edmonton. I'm a clinical pharmacist by background, and then I've spent the last 25 years really in the health system, the Alberta Health Services area, managing many teams in hospitals and clinical excellence, and then most recently worked in the government of Alberta with their public drug plan and public insurance plan. And I'm really proud to be here, part of PHARMAC. Thank you. Thank you for the opportunity to speak today. I'll try to know as many answers as I can with my 11 weeks. Thank you.
It's not a quiz.
Would be nice. Members, Ricardo.
Thank you. I just had some questions on staff turnover, which has increased from last term. You noted in your report that relocating is one of the more common reasons for the increase in staff turnover. Could you outline what are some of the other reasons other than relocating that have been at the top?
Yeah, I mean, that's very operational. So it's probably more appropriate that you do, but we do get a report to the board quite regularly. You know, some is a younger workforce, so we've got very, very smart people that work for us. And so often we're a stepping stone to them going on to other opportunities would be fair as well.
I would say, thanks, Paul.
Mm.
It's one of the things when I came on that I also picked up on and we've asked the team to pull together what their engagement retention plan is. And I think the FAR committee has also asked for an in-depth review of all of the reasons, and we can provide some of those next time we're here. But in general, the relocation is a big driver. We do lose a number of people to our supplier community because they are quite young, mobile, technical expert group. And then I think, you know, there has been a period of change, and periods of change often do cause some challenges with retaining people where they want to try other options. We're a small organization, and so sometimes progression can be difficult. We have a very stable retention rate for our tier 3 and above managers. So sometimes there isn't the number of opportunities to move through our small organization.
Do you conduct pulse surveys in
We-
the workplace?
we
And if so,
do.
what are the results of these?
The pulse surveys have shown our engagement to be steady, although we're trying to improve. Our team has an engagement plan with the staff. And our people leaders meet regularly. Our reports to our FAR committee show great positive culture amongst our people leaders. And we've got a plan which includes bringing on expertise that we've retained to do presentations, and the staff looked at our engagement survey and they were able to give input into what areas they would like to most concentrate on for the upcoming year. And one of the areas they've picked was feedback, how to give better feedback to their own staff members and colleagues in a professional and sort of growth mindset way. So that's one area of focus that we have this year.
And just
Thanks.
finally, you're looking to replace every staff that you've basically lost at this point. You're moving away.
Yes, and yes,
We've got more staff now than we had 12 months ago, mainly because of the work that was going on last year. So certainly we've increased the number of staff, and even changes within the organisation in general. People are getting other opportunities within the organisation at the moment because we are stretched.
Hamish.
Excellent, thank you. And you've kind of alluded to it already in some of your answers about the reset program. So PHARMAC, of course, has had a number of reviews since 2021, I suppose. So can you give us some examples? I think there was 33 recommendations that PHARMAC had, and I think there was a document from July this year which ticked a number of those off. How are you progressing with the others to date? And are there any concrete examples of how you're incorporating consumer voice in PHARMAC's operations?
I mean, as Natalie has identified, PHARMAC's been through a lot in the last few years, and certainly from that 2022 review, then to the cultural review, then to the consumer engagement workshops. It sort of got to the stage for the board, really, where we just went enough. Like we know what needs to be done, It's now a matter of execution and how we do it. Equally, because they've been so incredibly busy, you know, the 83 new medicines and then another 14 or another 18 in the last few months, you know, that's extraordinary. So you've got to make sure that they're doing the number one job, which is the assessment and negotiating and getting those medicines to New Zealanders as quickly as possible. Alongside of that, we're trying to do a whole new reset of an organisation that was pretty much the same as it's been since 1993 when it was brought in. So we went back and did another look at the 2022 review. We went through, and I'm not going to get my numbers exactly right, so someone can correct me if I don't, but from memory, we kind of went of the 33, my math's not going to add up, so there we go, we'll just go with that right now. But of that, I think it was something like 19 we were able to say completed. There was about 17, so my math's probably not already, but there was another whole lot that were almost superseded by other work that had happened, and then there's always a couple that need to keep going. It's quite interesting because now we report to the 90-day reset program they do to the board, and that's quite interesting. And I think we had 5 sort of priorities for the first 90 days, and feedback that we got was that, you know, a little over ambitious for the capability and capacity within the organisation. But then equally, when you touch on consumer engagement, it, you know, the traffic light said in progress, and certainly the board went back and said, I hope it always stays in progress because I'd hope it's never done. You know what I mean? Like if we're not constantly changing our engagement, looking at what we're doing, being brutally honest with ourselves and with them. The chief executive is it monthly that you do with consumers and with patient advocate groups?
Yes, we have a monthly consumer group where we get all of their input, feedback, discussions on consultations that have maybe gone out the month before. It's been quite helpful.
And then with that, now we've got the consumer and patient working group. So they selected the members for that. They selected the chair. That was not, we set up the mechanisms, but for me around transparency, openness, you've got to let them own actually how they're doing it. So there's, you know, for too long, PHARMAC had kind of almost set it up, and so there's a lot of departments, you know, where you sort of know what you want the outcome to be and how to do it, and then, you know, massage that into what it is. So their terms of reference are theirs. We are there to support, provide the secretariat to help with the work program as far as what we see as priorities. But the first time we're actually pulling the whole HTA to bits, you know, like 16 steps, and some of them low risk, you know, like I'm not from a medical background, right? So I just couldn't understand it at all, you know, and then we're not getting through the assessments in the time that we should at all. And you've got to sort of sit back and go, why? So now I think we've got PTAC being more actively involved, clinicians we're looking at, but we will seriously look at assessments differently.
Can I just tell? One of those recommendations was around rare disorders. And PHARMAC is reviewing their rare disorder policy settings to align with a strategy that was published in July 2024. Can you give us an update on where PHARMAC is with this work in rare disorders?
I think we're off to a good start with a redefinition of what a rare disorder really is. So it's not ultra rare and unbelievable, it's now 1 in 2,000. So that brings that down to the kinds of diseases that you may know someone with a family with someone affected by this disease. So that brings that group of rare disorders right into our sights. It's not easy meeting the expectations of rare disorders groups, but at least we're in step with other parties, including the ministry. And we have to do what we've been doing with all the reset work, which is not just listen, but actually hear. Because when we actually hear from people with lived experiences, and when we think about how an investment here could actually impact throughout their life, not just for the next year with hospitalisations or whatever, but for the rest of their lives, their economic and social possibilities, we can frame, if you like, the investment benefit in a different way. And that's the kind of work we're on. That's the journey we're on. But it does come down to engaging with that group, working with them, hearing their expectations and trying as best as we can to fund some of the pharmaceuticals and devices which will make a difference to them and their whānau.
We heard a lot in the Valuing Life summit. And rare disorders are certainly a part of that consumer and patient advocacy working group. And, you know, one of our, you know, as I hope we talk more about that HTA, because I can see you making like, you know, equally with that as well as, you know, what are the funding streams? And, you know, and I'm being open-minded here and big thinking, you know, certainly not a decision by us, but, you know, are there different streams of funding? So you're keeping true to the PHARMAC model, but, you know, a really rare disorder is unlikely to be funded if you keep doing it the way that we are with, you know, such limited funds. And it's just not fair, you know, and it really isn't fair. So when you look at it quite differently, that is part of the work that we're looking at doing over the next year or two. And there's differences of opinions. So you can speak to some who are from rare disorders and they'll go, yes, ring fence us some money. And then you go to others and they'll say, do not ring fence money. It didn't work last time. Criteria changes, you know, like, so, you know, like we all think we know the answer, but effectively it's wonderfully challenging and something that we're really keen to take on.
Thanks. I just want to use a set of questions to have some back and forth to understand the reset better. I've looked at the material on the website as well. And I saw in both the culture review summary that has been released that there needs to be a new set of strategic priorities for PHARMAC. And I think your answer to the last set of questions touches on some of that. The website has details of a 90-day plan and some early initiatives that are underway about consumer engagement. But can you describe what the bit about strategy is? And I see the points made in the documentation that there's a desire to get away from what's in the statement of intent, which tends to be, the letter of expectations, which tends to be narrow, and instead to get to something else and something else that's more widely consulted. Can you describe how you're defining the something else in terms of strategy, please?
I mean, in the first instance was even, and it was certainly from the Debbie Francis Cultural Review, was around vision and strategy. And to be quite honest with you, you know, our staff couldn't clearly define what our vision and what the future looked like and what we were trying to accomplish outside of fund more medicines as effectively as we could. You know, so that sort of pulls you right back into the strategy, brings you back into the values of the organisation. So the feedback that we got is that from that review and the board was that actually people were there for the right reasons, which was their hearts and their heads were to deliver for New Zealanders. They weren't quite sure that the organisation itself was strategically framed to be able to define that.
So how are you, this sounds like a positive project and it sounds like, but part of, there is that formal link between what's in the Act, the letter of expectations, those sort of narrowly defined PHARMAC functions. So could you just elaborate, maybe cast ahead a bit of where you are at the moment to what the strategy might be so that we can understand it?
Yeah, we're doing both. So, you know, the board sees the 13 points against the letter of expectation and our progress that the staff have made, you know, because we've got to deliver to the government, to the minister. So that is certainly very important to us. And to be honest, most of it aligns. And in fact, his first expectation was around culture and ensuring that we were getting that right. I think that we are not there. And that's because we want to bring other people. So I can't sit here and define to you what I think that strategy will look like, because I don't believe it's up to me and I don't even believe it's up to the board. That we have to be doing it with New Zealanders and particularly with those that are actively invested with the organisation. And there's amazing clinicians out there, you know, 240 of them across 31 different specialist committees that give their expertise for pretty much nothing, you know, to PHARMAC. And, you know, Margaret, you've got a view on, we're not using them as effectively as we could, you know, like it's kind of like, do you think we should fund this medicine? They do amazing research and everything, but do we actually ask them what the future looks like and how we do it, you know?
Can I take it then the proposal in setting a wider strategy for PHARMAC is going to, you're making plans around a consultation to
Absolutely.
do
So
that.
everything will be done externally and with as much transparency as we possibly could. It's a bit like when I said we set up that committee, that working group. We didn't want to define exactly what it was and then you can all just fit in and whether it suits you or not, we're trying to build it with, with our external partners so that it's not just a government initiative from a Crown entity. It is genuinely, and it's confronting, those consumer engagement workshops were incredibly confronting for the board. When you hear about someone that's had a lived experience and went in front of PTAC and, was with a rare disorder and was, begging for their life and their brothers.
Mm.
And we're told you're 2 minutes up now and no one got in touch with them afterwards.
Mhm. Yeah.
So we've got so much to do.
And just on the scope side of the strategy, there's often discussion around and we've had back and forth on this at Select Committee previously. There's a request for a medicine strategy from part of the sector. And I think last time I asked you, which was a year ago, it wasn't yet defined whether that was PHARMAC's job or someone else's job in the system. Is this PHARMAC strategy reset something about a medicine strategy, or is that something else?
We can, Natalie's keen to talk about the process and where we're at the moment, so I'll let you do that. We've got a unique opportunity right now, I think. We've got new leadership across Health New Zealand, across PHARMAC, across the Ministry of Health, actually. So I think I think that certainly what I'm seeing from these leaders is that they want to work quite differently as well, so that we really are thinking about, and there was a lot of discussion about a medicine strategy at the Valuing Life Summit. And again, really interesting. I suppose I've just got my own opinions, and it's just, we didn't know 2 years ago that a diabetes medicine could actually potentially change, operations for knees and hips and people's health, with weight loss. We didn't know 5-6 years ago that, you could suck blood clots out of, someone with a stroke brain and they can be fine an hour later. So I agree with the medicine strategy at some level, but there was quite a lot of disagreement about what that looks like.
But it was, sorry, Mr. Chair, if I may, is that the work PHARMAC is doing? Or is PHARMAC doing how we're going to run PHARMAC? Yeah, got it. Thank you.
And so do you want a little more on the reset process?
I was just, to what Paula said, we're really focused on with the vision and strategy piece we've started actively with our staff to make sure we can bring them along, work on the vision. We've been consulting with various groups, our consumer groups, PTAC, on what does the next decade look like for you? And our strategy will be really focused on our core business, making sure that we're, making the right choices, making the right investments, doing that with people engaging appropriately from a health equity perspective, timely access, best outcomes, and then our commercial approaches. So I think we're trying to focus that strategy around our core business, and then that will enable us to feed into medicine strategy, rare disease strategy. When we've got our sort of house in order and able to really move forward with that, we'll be able to feed best into, the wider sector. And we'll be coming out to external groups as well to consult on that after Christmas.
Thank you.
Thank you, Mr. Chair. We actually see an announcement today about PHARMAC proposal to improve rural access to emergency medicine. Do you think you can give the committee a bit more detail on this proposal?
Can I look at you?
This relates to those who are in the emergency sector, such as ambulance crew, for example, or first responders, being able to have access to the right therapeutics and not have to worry about some of the regulations that would have impeded them as non-prescribers to have those medications. So, for example, if you're on the far north and you're not going to be able to see a doctor or even another type of registered health professional that has prescribing rights, you now can see an ambulance crew that can carry and can have the medications and administer them in a broader remit than they've previously been able to do, and have that supply. It also applies to, I think, community midwives as well, having a broader supply. Our technical team, if they're nodding, I'm saying the right things, that's good.
So how can that improve the patient well-being?
Well, because if you're in a rural area in New Zealand, and you have an acute event, you're a long way from help. So having those health professionals, such as our ambulance crew, our community midwives, etc., being able to have a better kit at their fingertips when they're trying to deal with your acute and potentially life-threatening condition will certainly benefit them.
Does that mean that they need to do extra paperwork afterwards, or because it's emergency medicine, right? So they probably got to prescribe or use the medicine before they get approval. Is
I
that-
don't necessarily think so. I think it will make their work more satisfying and ultimately with a better outcome for the patients. There will be less paperwork, I would hope. But no, I don't think so.
Thank you.
Ricardo.
Going back to some of the questions I was asking the minister on public trust. Are you satisfied where you rank compared to other public agencies when it comes to public trust, and specifically where you're tracking on trust in Māori?
Well, we measure that. I can't remember the tool. The team can tell us which tool we use to have an assessment of public trust. I think it's fair to say that the board really did consider that our public trust had been a bit dented with the events that played out 18 months to 2 years ago. And we've had to earn that trust. And the way to earn it clearly is through our consumers that with lived experiences who we've invited in to help us with the reset and ultimately with reshaping how we do our work as much as what we do. I think we have to earn the public trust by being more responsive, which means we do things better, but also faster. And that there's more certainty for people in New Zealand with health conditions who require medical devices and pharmaceuticals, that their medication that they wish to have can or can't, because sometimes we simply can't fund, but having certainty allows people to make decisions and other choices. It's the uncertainty in the clinical arena which is so very difficult for people with health issues. So I think we're on a journey to increasing that public trust. It's certainly the goal of the boards to secure that.
It's certainly, some of the past is, and well before any of our time sort of thing, but, you're saying no more often than you're saying yes, because you just don't have the funding, right? And as I say, the people that work at PHARMAC are there because they actually want to and genuinely care and want to be doing that. But when you're having to say no to people a lot more, what happened was the walls came up. And they got more internally focused instead of looking externally. So understanding that through the couple of reviews that we've seen, and now having this reset program that is about engaging, openness, transparency. I mean, wow, the difference in 12 months at the Valuing Life Summit for me was palpable, but that doesn't mean we still don't have a long way to go. So when you're applying or you put an application in for a medicine and you're not hearing anything back from us and you feel like it's just gone into the ether, that's really disengaging. Now we've got absolute processes in place that we are communicating.
And so I'm referencing page 39 of the report, and this is in relation to public trust and your priorities more broadly as well in relationship to that. When it came to Te Tiriti o Waitangi, you noted in response to your achievements, quote, with changing government priorities, we're shifting to a focus on Māori being a high health needs population along with others. What did you mean by changing government priorities in relationship to Te Tiriti o Waitangi?
The cabinet have done a cabinet circular that's made it very clear that they want it on needs and not on ethnicity. And so for us, we had to look at our organisation and make sure that we're in line with the cabinet circular. Equally, the first letter of expectations from our minister was quite clear. So for us as an organisation, we need to sit down and have a look at that. We have made changes. As you know, I mean, it was more than a year ago, so it doesn't sort of fit in with this, but, we made changes to the Māori advisory, to the Te Raupu. We also, we had a treaty policy and the board made the decision a little while ago we're the only Crown entity that had that, and that actually we should be coming under Health New Zealand, and we should be coming under the expectations of a Crown Entities Act as to what we should be doing to be doing that. So we've certainly we've certainly consulted with our staff and then have changed that. But a Māori directorate, we couldn't see how that was delivering best for the organisation and for Māori either. You know, at the end of the day, we want to make sure that we have a Māori responsiveness that's right throughout the organisation and not a tick box that's sitting in a corner, which I'm not going to say it was a tick box, but, you know, it felt like we could go, oh, that's okay, it's, you know, here it is here. It should be, you know, need should be implemented throughout the whole organisation. And Margaret, you've got strong views on, good strong views on actually on need and equity and that it's real.
Yeah, it's real. And sometimes ethnicity is the best marker of that inequity. But we do have the high needs populations defined for us, and Māori is at the top of the list there. There's Māori and Pacifica and rural and women and so on. But we're very mindful that for some conditions, ethnicity really does equal the inequity that we have to address, and we're very, very clear that we must address inequities and high health needs. So we're not taking our eye off Māori at all, simply because there has been some change in legislation.
So we still take it into consideration, or certainly the team doing the experts do, you know, around health need and inequities when they're making decisions around medicines or where they sit on the priority list. The difference, I think, though, now is, so that might move it around because there is a higher health need. The difference now, though, is that certainly under current government expectations and under this board, we would not be signing off that Māori alone would get access to a medicine under a different set of criteria based on their ethnicity. So that medicine may get priority, it might still get there because of us taking those factors, but it's just kind of unfathomable that it's based on ethnicity that you get access to a medicine. That might mean that we're more likely to fund it, but we would fund it for everyone that fits the criteria of that medicine.
But I kind of heard two different things just now.
Because they are different things.
They are different things.
I mean, an acknowledgement that ethnicity actually can play, it can, and in some cases it's actually a really like important factor, right?
But
what are you, just to finish my question, like what are you tangibly doing different from shifting to a Tiriti framework towards, I guess, just putting Māori as a high health needs population group while also acknowledging that actually ethnicity is a key factor in addressing health inequities?
We can't ignore ethnicity because it's sort of inextricably linked with inequities. But our focus has to be on need and inequities, first and foremost, because of the policy setting in which we are at. But they're almost a mirror for some conditions. But it may not, and I'm just trying to think really good. The best one is lung cancer. And of course, we don't have in lung cancer medications that can fit this argument well. We do when we're building up a screening program, can fit it well. The next, I guess, diabetes would be a very good example where we know there is a higher prevalence of diabetes complications in some ethnic groups, including Māori. But when we come to our policy setting, we have to frame our funding decisions in line with government expectations around need, even acknowledging that ethnicity is a very good marker for that.
So we can take it in as a factor for consideration in whether or not we fund and where it sits on priority, but it doesn't mean it would be going just to that ethnicity.
Jenny, you have a sup?
Yes, we've been talking a lot about your research, excuse me. And, you know, in 2 years you've had, we've got a new minister for PHARMAC and which is a big shift from what it was previously. You've had the reviews and you're undergoing this big culture shift and all that. What length of time do you think it's going to take till PHARMAC is functioning, how the public sees the total value and the improvement in health gain and where you no longer have marches in the streets? How long is that process going to take? As long as a piece of string, I know.
Okay. So, I mean, the research program itself is 5 years. You know, so we've got, as I say, that first 12 months of which we are about 6 months in, Michael, yes. So about 6 months into that, so we've got about another 6 months, and then we've got another 4-year program that we're working on, and we do a 90-day within it. So we've broken down what does it look like in 5 years. We've broken it down into 12-month chunks, and then we've broken it down into 90-day that we can actually do an assessment against as to the progress that we're making. So I just go continuous improvement and continuous improvement, and I can already see a massive change in our engagement. You know, trust me, patient advocates and consumers, they were not shy in telling me exactly what they thought, and they're still not. It's just more often positive now than it was negative. You know, like, I mean, it's embarrassing actually, but, you know, they would sort of say, we would ring and the phone wouldn't be picked up and no one would call us back. And they just go, now we're proactively getting involved and ask questions early. And if we think it might be contentious, we ring up the right people and go, have we got this right? Have we got it wrong? Natalie and I went round and met a whole lot of clinicians a few weeks ago, and it was just fascinating for them. You know, one of the head of cancer, and, you know, and he'd never met with the chair or chief executive at PHARMAC. You know, and so to have those kinds of conversations and build those relationships so we can ask questions and get direct answers but you will always have protests in the street, I'm afraid, and petitions coming to Parliament, because we can't fund all of the medicines that people expect and they want. And that's in some respects getting more difficult as we see the rapid changes and advancements in both medical devices and medicines. And as such, everybody's expectation, and they're very expensive, and everyone's expectations are that they should get it.
So supplementary on that, Mr. Chair. So in terms of those medicines, and where we're still seeing overseas standard of care medicines, but not currently available in New Zealand, how long will it take? Is it just budget uplift, or part of this change process where we can start seeing New Zealand lifted, you know, from that bottom ranking of 20 on the OECD list in terms of
I think we can
access?
do it better, and I think we can do it more transparently and openly, and I think we should be looking at our processes and everything all of the time. But we will only really be able to fund many more medicines by getting, and it's, look, just $1 billion, she says with a wry smile, but that would just about clear that OFI. I think it's a bit more than that now, and, you know, as they say, and it's true, we are at the bottom of those sort of 32 countries, and you can get access to, I think, and I can be corrected, but I think 82 more medicines, you know, in Australia than you can here in New Zealand. And that is, we do spend every penny, I promise you. In fact, sometimes overspend, you know, as far as we're getting a bit ahead of it and then promising for out years and then having to take from that. There's not much more we can do without the funding to do it.
Final sup on that. In terms of the OFI list, some have been sitting on those lists for a very long time. Is it fair to say that actually some of those medicines no longer are currently, you know, best in class? Is there a shuffling that happens on the OFI list?
So decline that we're doing.
Yeah, be good, quite good to understand.
Yeah, thank you. Certainly, as we have new medicines come on, others rank higher than some of the lower ones on the list. And the ranking is something that's definitely contentious about people wanting to see the rankings. We have a consultation out around whether we should, if things have been on there a long time and are no longer potentially the ones we would fund or likely to fund, should we take them off the list? And we've heard a lot of feedback back around that question. And I think we're looking at all that, and we'll have to make a decision. There's some people that say, hey, we should say these are no longer there and it could come off the list, especially ones that maybe we don't think are as contemporary or would be fundable in the near future. And there are others that are very strident in wanting to keep them on, no matter what, even if there's a hope that they may be funded later. So we're openly consulting on that. I think the consultation just closed, and I know Adrian can tell you more about that, but certainly something we're looking at.
Supplementary.
Have a sup for.
Yeah, I've got
Andrew
two very
first.
quick subs, thanks. Just trying to reconcile the different parts of your answer to Ricardo's question. The first is, just to be really clear, what's PHARMAC's position? Is ethnicity clinically relevant?
That's a very good question to answer, because as a clinician, I'm always going to say that ethnicity is clinically relevant. But in respect of what we do in our business that we run, we are focused on needs in the current policy setting.
Okay.
But it doesn't mean to say we don't notice or take notice of ethnicity for the reasons I spoke before. But in this current policy setting, we are focusing on need, and we have the strategic high needs population. So that's Maori, Pacific, rural, children and women. I think I've got the 5 right.
That's
So-
probably answered my second one.
Yes,
Okay,
thank you.
Ashley, you had us up on that?
I did. I think items being moved off the options for investment list. I understand you're in the middle of responding to your consultation, so I won't ask you to preempt where you go with that, but it seems a part of that puzzle would be, let's say you remove an item that is no longer the best antihypertensive that we should purchase next because there's others out there. If you remove it, would you go look for the other one?
We've been discussing that, haven't we, at length?
It's a very good.
And how proactive we should be,
Exactly,
actually.
yeah.
And because, you know, we've been talking a lot about, you know, we don't ask for applications as such. We're the only country in the world, though, that gets so many applications from clinicians and from patients, about half of them now, which is extraordinary, which slows down our process, I've got to be really honest, because pharmaceutical companies give us a lot more data and a lot more research and a lot more of all of that. So we've often, and then you go back to a busy clinician and they've, look, I gave him as much information as I've got, and you know, and so that can really delay things. But the decline things, hence going out there and talking openly about it, because it is controversial. So some, as Nelly said, some are going, look, if I'm going to be sitting at the bottom, but I had a specialist only in New Zealand who, you know, sat down at my table and at the airport, and he said, I got a phone call the other day, and he said, my initial was, yep, you may as well, you know, if it's going to be, if it's that low, you may as well decline. Goes, then I rang back and went, no, hold on a minute, if there's a better medicine, I need to get that application in first and make sure that that's in the mix before you take the other one off. And, you know, so.
Yeah, I think we've had some similar feedback. And we'll go through it all. Adrian is going through all of the various pieces of feedback. I think we don't currently have that process where if we take a class off of a list, well, we don't take anything off the list now. It stays on forever. But, you know, that active looking at the class, making sure we have the right first line or second line therapies on the OFI, et cetera. I think that's what you're asking.
Correct. Yeah.
Some of it, I mean, if Dr. David Hughes was here, you know, because I've asked lots of these sorts of questions, and he would say we've always got an eye out of what's happening in the world and what's coming up, or gaps where we just don't think we do have medicines for a particular disease or a particular. And so, you know, he said it might not be that we're you know, but we might be bringing up and saying, hey, have you got this in the mix? You know, are you looking at? And, you know, sometimes when we're asked why aren't we funding, and it's like, well, we haven't even got an application for it yet.
But yeah, I will say that it's my understanding, I haven't been at all the PTAC meetings, but David certainly made clear that in the PTAC discussions, when they're looking at what they're recommending, they will often go and there's a gap here, and someone will actually put in an application. It could be by the committee or another clinician to make sure that we've covered off.
If I could just pick up on Ms. Bennett's earlier comments that we have the highest rate of submissions from clinicians, and sometimes their patient groups, aren't they, that make the professional societies make the submissions, and in the world. Well, does that reflect it? And that they are hard for you to manage because they don't provide all the same information a pharmaceutical company would provide. Is that not suggesting there's a role for government here in actually taking on that workload and not leaving it to busy clinicians to do after?
Potentially.
Yeah.
And it's part of that HTA process, you know, that we're looking at completely pulling it all
Right.
to bits. The first step is application, right? So we've made it easier for people to apply, and hence why we're getting more of them, and we encourage them, and so that's part of the reason we're getting so many more from them. But equally, that's part of the questions that we're doing as we work our way through those, hopefully fewer than 16 steps in the future.
And Mr. Chair will be, now I'll be allowed my primary question.
No, you won't. Sorry. Go to Hamish.
Excellent. Well,
You're on the list.
kind of leading on probably from that answer that actually you've just given. How do you intend to take a long-term view of your approach to funding and investment? And you've talked a lot about kind of changing the health technology assessment. You've talked about kind of reaching out through the application process to kind of see what needs, what should be different groups actually want. How are you going to take a long-term view to kind of how we're going to navigate forward in the purchasing of medicines for New Zealand?
Yeah, I mean, Natalie can probably speak to that, but you touched on it with the minister, $150 million in savings that we were able to then completely reinvest into medicines. That was from how we negotiate and how we do it. And the fact that people actually don't know the list. They know the list, sorry, but they don't know the priority ranking on the list, gives us power. Because when we go to negotiate, if they play, we can go, well, we can just go to the next one on the list and come back to you in a few months, because we're going to get a faster and a better deal. And so it does sort of have some acute thinking for people as well. I don't think people understand the rebate part of, Natalie, and you and I were talking about that this morning, and I think this might be a good opportunity because this is unique to how it goes.
Well, I think one of the, as you know, and you can see in our annual statements, the team has strong negotiating and commercial approaches that some of those, the ranking of the OFI and having that as commercially sensitive material helps with that. But as you can see, for the $1.6 billion that's invested in medicines by the Crown, our active group is able to negotiate over just about $1 billion worth of rebates from companies through the commercial approaches we take, which means we have $2.7 billion worth of medicines delivered from the $1.6 billion of Crown money. So that's an excellent return on medicines for New Zealand. And part of our process, in terms of how we do that, the team has excellent commercial approaches, negotiation tactics, and some of these things that are difficult sometimes to understand help with that. The process, how are we going to improve it and how timely it is, and Dr. Varel's comments around, can we make it easier up front? That may require some investment, as you say, and we've invested in other parts of the process, more health economics support so that we can get through applications faster. And then we have to look, as Paula says, about what the 10-year view that you spoke of is, how there aren't enough people to really make sure we're as efficient as possible. So AI, where can it help us in the process? And how do we create some expedited pathways that also reduce our risk, still maintain our commercial approaches, still address patient family needs, make high needs groups, but maybe if they're a small expenditure or a small group, we can expedite through some of our processes. So they're all things we're looking at to try.
And we haven't even touched on sort of societal impact and, social investment, which I think I should just put that in the hands of the committee, because, that's, if you want to talk more about that, but that's fascinating.
Well, I think kind of that's probably actually where I was kind of going.
Yeah, no, that's
with kind of going forward. Actually, the strategic kind of role of investment in pharmaceuticals.
Obviously, I can't, and wouldn't name medicines and things like that, but there's things that we could fund now that we know, and we already look at that overall health savings. But what sort of weighting we give that has been interesting. As you can imagine, with social investment, working age populations. And so I don't think social investment will work for every medicine all of the time, because that just wouldn't be fair and not the New Zealand kind of way that we do things. But there are medicines that we could prove that you could invest to save. you know, and you can think about knee and hip operations, where they come from. You can think about things like, you know, a multitude of illnesses that actually, with the technology and the way it's going, if we were able to, I mean, a great example is around SMA, I'm going to use, because, you know, we now fund that for children and the drug for them to get there earlier. Now we're heel pricking the baby and doing the test on SMA. And from memory, we met with Dr. Brady, from memory, there's like 5 a year, like it's like 3 to 5 a year. So it's not many. So we fund the medication that they can get, and getting that means that it's a degenerative disease. So as such, they're keeping their bodily, you know, they're getting motor, their normal development is what I want to say, is what we can see. But there's going to be, instead of them having to have, you know, monthly injections or daily pills, it's going to get to us, you know, there's a gene therapy now that they can be given once. So
Historically, what we've done in assessing whether or not to fund a new medicine is to look at it from a health economic model. And that's very much anchored around the kind of benefits that are published or advertised through clinical trial publications in scientific journals. And those are often clinical measures. They've increasingly started to, the journals have required, or the sponsors of the trials have required, some patient-related outcome measures. But broader economic and societal or social measures are simply not captured in those kind of analyses, because the origins of that information come from the clinical trial work establishing the drug works and is safe. But our consideration of social investment principles is that maybe a drug wouldn't score so highly on a traditional cost utility or health economics analysis, but might score higher if you look at years of productive working or contribution to family and whānau welfare, for example. And maybe we should invest with some of those broader measures in mind. And we're just exploring how to do that. And we've done some provisional work with the University of Erasmus in Holland. So more to come in that space. The other point you made reference before was around the growth in health technologies. You referenced CAR T-cell therapy, and it's come up once, but how do we as a sector, because it's not just us, it's Ministry of Health around policy settings and regulations, it's Health New Zealand that has to administer such therapies. How do we as a country look at where those therapies will sit in our repertoire of therapeutics? And how should we fund them? And it's a huge piece of work, and we probably only have maybe 10 years worth of data out of CAR T-cell therapy, and it's very much been individual and quasi-experimental use of the therapy. So we don't know where it's going to sit in terms of long-term benefits. We don't have those data yet. So a lot of work to do in that space, I think, strategically for us, but the health sector as a whole.
Yes, so is PHARMAC doing any work around CAR T-cell, and how PHARMAC will be looking to participate? Appreciate it could be a joint thing between Health New Zealand, since there is multiple parts to it.
So I'll just comment. We have the Cancer Agency leading a multi-agency working group, to which we have our Chief Medical Officer, David Hughes, participating, along with Health New Zealand, the Ministry of Health, to look at how we're going to really approach CAR T strategically, as well as we have applications in for the parts of the CAR T process that would be the medicine part that Dr. Varel commented about. But as you know, it requires, you know, lab resources in Health New Zealand, technical expertise to be able to really deliver it. So it's going to be an all agency effort to make sure that we've delivered CAR T therapy.
You can just tap on that again. So I appreciate CAR T-cell that you've got the Cancer Agency leading that work. It's not out of the realm of possibility that it may be used also for autoimmune diseases or non-cancer conditions. Do you think kind of the work the Cancer Agency is leading could then be mirrored for other disease areas?
I do think it will be a model, because I think there will be many. I anticipate there'll be many other therapies into the future that would have this, that will become more and more complex and have a technology component as well as a medicine component and a large impact in maybe new ways of delivering within Health New Zealand and expertise that's needed on the medical side to enable it. So I think it can serve as a model for how we'll do that in the future.
Okay, we've got primaries, just so everyone knows we're ready. Cam, Aisha, Ingrid, Jenny.
Mine was a primary, but it seems like a sup after that question, mine, which is about the Cancer Control Agency and the work that PHARMAC does with the Cancer Control Agency. What you talked about what's happening with the CAR T cell leadership that Cancer Control Agency is doing. Has there been any other value that you've been able to leverage from having the Cancer Control Agency in the public framework? Has there been any medicines that are funded because of the work the Cancer Control Agency does? What is the Cancer Control Agency contributing to the scheme that you've been able to leverage on?
Well, to be fair, 13 cancer medicines were funded last year and 604 million because they named it in the report and politics played its game and, and that's how that happened. Can't see that happening again, unfortunately, from a getting lots of money perspective. But so, that's probably at a high level what I could say. I mean, as I have said, we've got a unique opportunity with new leaders right across, and certainly the Cancer Control Agency is going to be the same. In that respect, I think that board chairs, ministers can have a very different expectation on how they work together. So instead of everyone sort of being in their four corners, and Health New Zealand kind of being the big brother that overrules everybody and you get on, I'm seeing much more collaboration, much more conversation, much more of that, I think, right across.
That's a fantastic thing to hear. I know, I guess to further to Dr. Campbell's point, CAR T cell, for example, could be used in compromised issues, but that's not something the Cancer Control Agency, being the leader of this working group, I think is what you called it. Do you think that having the Cancer Control Agency actually in the position is causing a narrowing of the scope, or
Not at all.
I guess
Does someone have to chair it?
what I'm trying to ask is, we've had Cancer Control Agency come in here and tell us that the work they've done has led to a whole lot of funding, and you've mentioned the 13 drugs, but I guess them being named in a report by the Cancer Control Agency, I'm just trying to find from your experience what other value they've brought to the system.
I don't think that's our role to actually give a judgment on another agency.
I thought it might not be, but I
and
was
the work
still
that they're
asking.
doing. So we should be public servants and stay in our lane, I think.
Yeah, and I will say that certainly all of the work that we've done with them has been extremely collaborative.
Nice.
Excellent. Hey, we can come back to this one, but it's almost 3 o'clock. I thought we'd stop for a 5-minute break. We can return then. So
Thank
it's
you.
suspended for 5 minutes. Very fast.